Hi everyone, today we are going to discuss about lipoma. Usually patients will come with the complaints of a painless swelling. It can occur all over the body. Usually the swelling will be soft, mobile, and it is not fixed to skin or any underlying structures. So the skin or the swelling will be normally pinchable. This picture shows a excision biopsy specimen of a lipoma. It appears like a well circumscribed neoplasm and the cut surface appears yellowish. This picture shows a microscopic image of a lipoma. These are all mature adipocytes. Usually these cells contain large fat droplets. The fat is removed in the tissue processing. So we are able to see only some clear spaces and in which each cell contains a peripherally pushed flattened nuclei. Usually superficial lipomas will be around less than 5 cm. Some deep-seated lipoma may go up to 20 centimeters. And some of the lipomas may show fat necrosis, calcification, and some lipomas like osteolipoma or chondrolipoma, they can show bone or cartilaginous areas. In microscopy of a lipoma, usually we are able to see only mature adipocytes without atypia. And fibrous septa may be variably present. There will not be any atypical hyperchromatic stromal cells. If they are present, we need to exclude atypical lipomatous tumor or well-differentiated liposarcoma. And intramuscular lipoma may infiltrate into muscle. It doesn't have any clinical impact. And sometimes we are able to see some atrophic muscle cells which can mimic some atypical stromal cells. Osteolipoma and chondrolipoma may show metaplastic bone or cartilaginous areas. Lipoma is a benign mesenchymal tumor composed of mature adipocytes. Usually they are painless, slow-growing, soft tumors. Some of the symptoms of lipoma depend on the site of the lipoma. When the tumor is large, it can compress peripheral nerves and cause pain or tenderness. Some of the GI lipomas can cause abdominal discomfort, obstruction or melena. And when there is multiple lipomas, we need to think of some other syndrome. Usually the etiology is unknown. Lipoma is the most common mesenchymal neoplasm in adult. It occurs in the peak of 5th to 7th decade and has a slight male predominance and associated with obesity, and it is rare in children. Pathogenesis of lipoma involves the gene HMGA2. The reactivation of HMGA2 expression lead to the development of lipoma. It is normally silenced in adult tissues. HMGA2 regulates the mesodermal lineage development during embryogenesis. We can divide the cytogenetics of lipoma into 4 types. The first will be rearrangements of 12q13. Second will be loss of 13q. And the third rearrangements of 6p21. And the last will be supernumerary ring chromosomes. This is the WHO criteria for lipoma. In essential criteria, we need to look for a classical circumscribed yellowish tan mass and the uniform proliferation of mature adipose tissue without any atypical hyperchromatic stromal cells in the microscopy. In desirable criteria, we need to look for some giant marker or ring chromosomes or MDM2 amplification in order to rule out atypical lipomatous tumor or a well-differentiated liposarcoma. These are some of the subtypes of lipoma. They are intramuscular lipoma, parasteal lipoma, osteolipoma, chondrolipoma, and lipoma arborescens, in which there is a reactive proliferation of lipomatous tissue, which usually occurs around the joints. This picture shows an intramuscular lipoma in which we are able to see some skeletal muscle bundles surrounded by adipose tissue. This is a picture of intramuscular lipoma. In the center, we are able to see some cells which appears like atypical cells, but they are atrophic skeletal muscle fibers which are surrounded by mature adipocytes. This picture shows osteolipoma, in which we are able to see some mature adipocytes In between, we are able to see some contromatous areas and some bony trabeculae. Thank you.